जी बात सुन, किससे कहेंगे पंखा लगा? Hello. Hello. Can you hear me? Okay. That's good. So let's start the lecture. ये पंखा मैंने कहा. Bismillahirrahmanirrahim. So the objectives of today's lecture are that by the end of this lecture, you shall have basic knowledge. Basic knowledge about symptoms of mixed anxiety and depressive disorder, its management. What is the difference between deliberate self-harm and suicide, and how you assess the suicidal risk in a patient, and a little bit about the management of patient with suicidal tendencies. So my message today is live life, and I would elaborate it at the end of the lecture. Now, what is anxiety? Anxiety is a feeling akin to fear or apprehension, and it is accompanied by disturbance in the autonomic nervous system, and usually there's overactivity of sympathetic nervous system. So anxiety arises whenever there is threat. And threat can arise from inner stimulus or outer stimulus. So when we perceive a situation to be threatening, we feel fear or apprehension. And due to that, there's secretion of noradrenaline and other neurotransmitters, and there are certain physical symptoms. And we give exaggerated meaning to those physical symptoms, which give rise to more threat and more fear. And this is how the cycle of anxiety is generated. So anxiety arises basically with the perception of threat or danger, okay? And depression arises whenever there is a loss. The loss might be real or it might be an imagined loss. and this gives rise to sadness. Okay, but mere presence of sadness or fear or anxiety doesn't mean that the person is suffering from a mental disorder. For a mental disorder to be diagnosed, there needs to be, certain set of symptoms which should be present for a certain period of time, and different dimensions of one's life are affected, like work, education, and other things. So mental disorder is a clinical significant disturbance in cognition, emotional regulation, or behavior that indicate dysfunction in mental functioning that is usually associated with significant distress or disability in work, relationship, or other areas of function. So that means that we might have, normal feeling of anxiety or fear or sadness, okay, or anger. That doesn't mean that we suffer from a psychiatric disorder or mental disorder. For a mental disorder to be diagnosed, there need to be a syndrome, multiple symptoms, and different areas of our functioning needs to be affected, and we need to have personal distress. So now we come to mixed anxiety and depressive disorder. Okay. Is it clear that we can have normal anxiety or normal depression or sadness? So what is mixed anxiety and depressive disorder? There are various anxiety disorders, like generalized anxiety disorder or obsessive compulsive disorder or phobic disorder, and there are various depressive disorders. So these are independent disorders, but this is a disorder in which anxiety and depressive features are mixed. Okay, so anxiety is part of depression in nearly 80-90% times, and depression can also accompany anxiety. But when we diagnose that a person is suffering mixed anxiety and depressive disorder, that means that symptoms of anxiety and depression are both present, but neither is clearly predominant, and neither type of symptom is present to the extent that justifies a diagnosis if considered separately. When both anxiety and depressive symptoms are present and severe enough to justify individual diagnosis, both diagnoses should be regarded, and this level should not be used. So this means that when there are mild symptoms of depression and anxiety both coexisting, then we can diagnose this disorder, mixed anxiety and depressive disorder. If, say, there are severe symptoms of anxiety and severe symptoms of depression, then we would diagnose that the person is suffering from, number one, anxiety disorder, and number two, depressive disorder. That would not be mixed anxiety and depressive disorder. Is it clear? Okay. So how can we diagnose this mixed anxiety and depressive disorder? So there needs to be symptoms present for 2 or more weeks. Okay. Then one is having sad mood most of the time, or loss of interest, or fatigue, and he or she cannot cope with the routines, duties, and there is anxiety or worry. Okay, worrying thoughts. So please note that these are also symptoms of depression: low mood, loss of interest or pleasure, fatigue. Okay, and This is anxiety, prominent anxiety or worry, inability to cope with routines. And other symptoms include disturbed sleep, poor concentration, change in appetite. These are also present in depression, okay? And there are dry mouth, tremor, palpitation, dizziness, aches and pains, suicidal thoughts of X might be there. But please keep in mind that this is a mild diagnosis. This is a mild disorder. This is not a severe disorder, okay? And there are no delusions or hallucinations, and symptoms are mild. When the symptoms would be severe, say symptoms of depression would be severe, then we would diagnose then, moderate depressive disorder or severe depressive disorder. So symptoms are the same of depression and anxiety mixed, but their severity is not that much. So then we diagnose it as mixed anxiety and depressive disorder. Okay. So differential diagnosis. Whenever you write the differential diagnosis of every disorder, you should first write in the differential diagnosis physical disorders, okay? And then psychiatric disorders. That we need to differentiate this disorder from physical disorders which can give symptoms of anxiety and depression. For example, endocrine disorders like hypothyroidism, okay? Side of effects of medication, can cause anxiety and depression. For example, medicines which are used for depression, beta blockers, they can cause depression. So in every disorder, when you write down the differential diagnosis, you would have to differentiate it from physical disorders and then psychiatric disorders. Okay. So you would have to differentiate mixed anxiety and depressive disorder from various anxiety disorders, like generalized anxiety disorder or phobic disorder. Then, of course, depressive disorder, for example, mild depression, mild depressive disorder. And if there are if there are mood changes and also features of depression, then you would have to diagnose differentiate it from bipolar affective disorder. Bipolar affective disorder is in which there are episodes of mania and depression. Sometimes mania or hypomania, and sometimes depression. And also a psychotic disorder like schizophrenia can present with symptoms of anxiety and depression initially. So this is a differential diagnosis. Now in management, you need to follow similar management guidelines. If you learn the pattern how to write the management, it would become easy for you that any disorder you can write, its management guidelines. Okay. So in the management, first is the assessment. Okay. You would write in each disorder these things: detailed history, physical, mental state, and cognitive state examination. Biopsychosocial assessment, biological investigation in keeping with the assessment and general causes of anxiety and depression. And of course, that you need to establish a trusting relationship. You need to show empathy, non-judgmental attitude, and various non-verbal and verbal communication skills, which you have already, learned. So in the management of each disorder, you would start like this, okay? And then And each disorder, you need to provide informational care to the patient and to the family. And you know what are the various questions which you need to answer in informational care session. What are the questions which you need to answer in informational care session? Can anybody write? What questions needs to be answered in an informational care session? Good. What else? Good. Very good. Parhez. Okay. Okay. So you would, yes, affect on people around you. Okay. So very good. Very good. सो आप इस तरह शुरू करेंगे कि ये एक दिमागी बीमारी है जिसको दबाव और उदासी की बीमारी कहते हैं। इसमें ज़हनी दबाव और उदासी की मुख्तलिफ अलामात साथ होती हैं, जिसमें उदासी, किसी चीज़ में दिल ना लगना, दिल की धड़कन तेज़ होना, हर वक्त परेशान रहना और दूसरी अलामात शामिल हैं। ये जब ज़िंदगी में कोई बड़ा वाक़या होता है, स्ट्रेस होती है और उसको हम सही तरीके से हैंडल नहीं कर सकते, तो अक्सर उसकी वजह से हमें ये बीमारी हो जाती है। और इस बीमारी में हमारा जो खून में और दिमाग का जो जूस है, उसमें कुछ कीमियाई मादे होते हैं जिनको न्यूरोट्रांसमीटर कहते हैं, उनकी कमी हो जाती है। ठीक है? तो ये बड़ी एक आम बीमारी है और इसका बड़ा अच्छा इलाज मौजूद है। इससे बातचीत से भी इलाज किया जाता है और दवाइयों का इलाज भी किया जाता है और अक्सर मरीज इससे ठीक हो जाते हैं। ये आप ज़हन में रखें कि मरीज को इस बीमारी में मुख्तलिफ किस्म की अलामात होती हैं, जैसे कि उसका सुस्ती महसूस होती है एक्सक्यूज मी, और कोई काम करने को दिल नहीं चाहता। तो आप उस पर ज़्यादा प्रेशर ना डालें और हर वक्त उस पर तनकीद ना करते रहें। ये सब कुछ बीमारी की वजह से हो रहा है, वो कुछ जानबूझ के नहीं कर रहा। और जो ही उसकी तबीयत ठीक होगी, उस साथ साथ उसमें उसकी तवानाई और उसकी जो बाकी चीज़ें हैं वो वापस आती जाएंगी। तो ये जो दवाइयाँ हैं, ये तकरीबन इनका असर करने में 2 हफ्ते लगते हैं। 2 हफ्ते के बाद मरीज का जो तबीयत है वो ज़्यादा संभलना शुरू हो जाती है। तो ये इस तरीके से आपने सारे एस्पेक्ट्स कवर करने हैं। ठीक है जी, इंफॉर्मेशनल केयर सेशन में। और कोई भी होगा, बीमारी होगी, उसकी इंफॉर्मेशनल केयर सेशन आपने इसी तरीके से करने हैं। ओके। So general assessment, trusting relationship, informational care, then in each case, you would need to decide that whether you would treat that patient in OPD or in a hospital. Okay? So you would have to write this point, okay? And you need to take measures to prevent the patient from harming himself or others, and treat any underlying physical disorder or comorbid physical or psychiatric disorder. The patient may be needed to be referred to the concerned consultant. So the point about admission, prevention of harm to self and others, and treatment of comorbid physical or psychiatric disorder. You would write these points in each patient, okay? And similarly, these skills you need to teach to every patient who suffers from psychiatric disorder. Education about diet, exercise and other activities, stress management, time and financial management, problem solving skills, social skills, and mindfulness skills. What are mindfulness skills? What is mindfulness? Anybody? Yes, mindfulness means that living in the present moment, and yoga is one form which can be used. Mindfulness means living in the present moment. Okay. And in counseling, the specific counseling which is used is called cognitive behavior therapy, okay? CBT. So, do you know what is cognitive model? Do you know what is cognitive model? No. Cognitive model is that we believe that a certain situation or event causes disturbance in us. If we denote event as A and our reaction as C, so we believe that A leads to C. Okay? That, for example, if a student gets low marks in an exam or supply in an exam, and his reaction is depression. So we think that the supply in the exam has caused depression in the student. That is, that A has led to C, but A does not lead to C. In between A and C, there is another letter which is called B. So what is B? B is the meaning which the student is giving to the supplementary, his thoughts, his perception. So he might be thinking that I'm an inadequate person, I'm no good, I'm a failure. And these thoughts lead to depression. Okay? So this is cognitive model that A does not lead to C, it is ABC. Okay? Is it clear? Is it clear? So this cognitive model forms the basis of cognitive behavior therapy. Okay? So in cognitive behavior therapy, you need to teach the patient that he or she should record his or her thoughts, and you educate him to challenge those thoughts and replace those with alternative thoughts. Okay? For example, this student who is thinking that he is a failure, this needs to be challenged. So he can challenge it with the evidence that he has been getting, very good marks in different exams. And since he was sick, so he was not able to prepare adequately for this exam and got the supplementary. Okay? So in cognitive behavior therapy, you challenge your thoughts and replace those thoughts with new thoughts, which help you to bring your reaction to a normal level. So this is CBT, okay? We would keep on discussing this CBT because CBT is used in almost each and every psychiatric disorder. And relaxation exercises, you might have studies, deep breathing exercises, progressive muscular relaxation exercises, okay? Imagery, and you encourage the patient to engage in more pleasurable activities, okay? And you help him to reattribute his physical symptoms, that these are not due to any physical illness, but due to anxiety or depression. So you can start antidepressant drugs or little bit of anxiolytic drugs, and you start with the low dosage, okay? And you gradually build up. For example, you can start escitalopram from 5 milligram, and then you can increase it to 10 milligram. So, of course, you would have to explain. You would have to explain in details about medications. Okay. You would tell the benefit and side effects of medication, and you would tell the patient that medication must be taken every day. And these work by increasing the level of chemicals in brain like serotonin, and improvement will occur gradually over next 2 to 3 weeks. And mild side effects may occur, and they usually finish in 7 to 10 days. These may include dryness of mouth, constipation, and excessive sweating. And you need to educate him that you would have to check with the doctor before stopping medication. And there's a need to continue antidepressant for next 6 to 8 months. I would be telling about reattribution in detail in the next lecture, okay? And if the suicidal risk is high or symptoms don't improve, then you need to refer the patient to the consultant, okay? So this was mixed anxiety and depressive disorder. So 2 weeks of symptoms, mild symptoms of anxiety and depression, okay? and management guidelines are similar, we would be repeating these management guidelines in other disorders that we would be studying, okay? Is it clear? So you need to differentiate normal anxiety and sadness. It's only human to become, anxious or apprehensive or become sad at times. So that doesn't mean that we are having psychiatric disorder. To diagnose a psychiatric disorder, uh, there need to be a set of symptoms, okay? And these should be present for a specific period of time, and various areas of our life need to be affected. Okay. So now I would be giving you a brief picture of deliberate self-harm and suicide, okay? This is a long area, and probably I cannot do justice in half an hour. So please try to grasp the main points, okay? What is deliberate self-harm? Deliberate self-harm is an act in which an individual deliberately causes injury or harm to himself or herself without the intent of committing suicide. Can you give an example of deliberate self-harm? Anybody? DSH. Can anybody give example of deliberate self-harm? This is deliberately causing injury. For example, cutting wrist, superficial lacerations, or taking overdose of, tranquilizers. Yes, they can do it, but I am asking about, examples from the normal life. So commonest deliberate self-harm in our setting is overdosage of medicines and, yes, sleeping pills. That is deliberate self-harm. So different people have different motives for deliberate self-harm. This might be a cry for help. They are in distress, okay? And this might be, some might, try to escape from their problems, okay? Or this might be a symptom of some underlying psychiatric disorder, okay? Like depression or borderline personality disorder. So this list is not given in your book. I've just given it. That if, for example, if a patient comes to you with overdose of medicine, so what are the factors which would determine that he or she would reattempt this deliberate self-harm? So previous attempt, personality disorder, alcohol, drug abuse, previous psychiatric treatment, unemployment, lower social class, criminal record, history of violence, 25 to 54 years of age, single, divorce, or separate. The more these factors are, there are more chances that the person would repeat the deliberate self-harm. Okay. For example, if there is a personality disorder and the person is using drugs, there are financial problems, okay, then the chances of repetition are more. So this is about DSH, okay, repetition of DSH. These questions are not given in your book, but I thought these are important, okay, that a patient has come with deliberate self-harm, and how do you assess deliberate self-harm? So first you would be assessing what was the patient's intention when he harmed himself. Okay, did he want to die or not? So how would you determine that the patient wanted to die? So there are certain pointers, okay? For example, if the patient used a lethal mean, okay, and if he wrote a suicidal note, and if he planned it, it was not impulsive act, but it was a planned act, and he did not try to get any help after the act. So these are the indicators that his attempt was serious. Okay, it was a planned attempt, and the method was violent, lethal, and he wrote a will or suicidal note, and he didn't ask for any help. And after that, you need to ask what are his intentions now. And we would return to this in the next section, okay? How to ask these questions. And you need to assess the patient's current problems and ask about the psychiatric disorder like depression. And you need to assess his or her social support. So these are the 5 areas you assess when a patient comes to you with deliberate self-harm. Is it clear? Is it clear? Okay. Management guideline would be similar as we would be discussing in the patient with suicidal intention, okay? Similar, detailed assessment, okay? Trusting relationship, decision about admission, okay? Treatment of underlying, psychiatric disorder, problem solving, okay? Psychotherapy. So I would come to this management in the next section when I would discuss suicide. So that was deliberate self-harm, okay? That is not suicide, okay? What is suicide? This is an act in which an individual deliberately causes injury or harm to himself or herself with the intent of ending his or her life. So when there is a suicidal attempt, there's intention to, kill oneself. And there are chances that after a suicidal attempt, one may still survive it. So that is called attempted suicide, okay? And when the patient dies, that is called completed suicide. And one thing that the patient with deliberate self-harm doesn't intend to die, but there can be, situations in which there are complications and he or she might end up in death as a result of deliberate self-harm. Similarly, the patient who tries to commit suicide he might not, die due to various reasons. And in that case, it is called attempted suicide. These slides are not given in your book, so I would request you to note down the slides. And these are the association of suicide, okay? Usually some psychiatric disorder or some, physical disorder is present, and we would repeat it when we would come to the risk factors of suicide. So these slides are not given in your book. Kindly note down, okay? So there are 5 areas in the risk assessment. First, you would ask specific questions about the suicidal intent. Then you would ask about any planning. Then you would explore the background, okay, past attempts and current problems. And then you would identify various risk factors which might be present in the patient. And then you would label the risk, whether it is mild risk or moderate or high risk of suicide. So these areas you need to explore, okay? And we would go in detail one by one. And interviewer skills you need, of course, you need to keep the confidentiality, and you need to develop the trust. For that, you would need to show empathy, okay? And allow emotional release while taking charge of the interview. And you need to raise the hope of the patient, confidence of the patient, and increase his or her self-esteem. And need to establish good rapport. Okay? So these are the general points, but very important points. If you are not accepting of the patient and you become judgmental or show anger, okay, then the things might get worse. So you need to be very, very sensitive, very, very respectful and empathetic and non-judgmental while dealing with a patient who comes with suicidal ideation. Clear? Clear? Okay, so you would be needing these interviewing skills and rapport to explore, to assess the suicidal risk. First area would be hopelessness. Hopelessness is the single best psychological predictor of suicidal risk. Second is you need to explore about current problems and past attempts, okay? Then the death question, and we would be reviewing it, how to ask this death question. And then you need to assess the degree and seriousness of intent, and you need to see various risk factors and factors which make suicide more or less likely. So now, go not to the quarter of despair, there's hope. Go not towards darkness, there are suns. So hopelessness is the best predictor of suicide. You need to assess it. So hopelessness, hope is about the view of the future, okay? Is there anything that you are looking forward to? आपको आगे अपने मुस्तकबिल में कोई उम्मीद की किरण नजर आती है, या आपको लगता है कि आपकी मुश्किलात सारी मुस्तकबिल में ख़त्म हो जाएंगी? सो you would specifically ask about the hopelessness. Then background knowledge, current problem, especially last 48 hours leading up to an attempt. Some conflict, some quarrel, some loss. Okay. What were the past triggers, the problems that triggered the previous suicidal or self-harm attempts? What was the degree and seriousness of those attempts? And how did the patient cope with his problems in the past? So this is the background knowledge. So first is hopelessness. Second, you need to know about the patient's current problems and his or her past suicidal attempts and his coping skills. Third is suicidal intent. How to ask the questions about the suicidal intent. So initially you need, try to normalize it, okay? How do you normalize it? You say that sometimes when people are distressed like you are, they think that life is not worth living. Is this something you have been thinking of? कि जब लोग इस तरह उदास और परेशान होते हैं तो उनके जहन में ये ख्याल आता है कि जिंदगी फजूल है, क्या इस किस्म की कोई बात आपके जहन में आती है? So this is normalization. Okay? People might get these thoughts, okay, temporary thoughts. Then you need to move from indirect to direct question. How the life feels to you nowadays? आजकल आपको अपनी जिंदगी कैसी लगती है? This is indirect question. नोट कर लें. आजकल आपको अपनी जिंदगी कैसी लगती है? ठीक है? Then you can ask another indirect question कि आप आजकल जिंदगी और मौत के बारे में क्या सोचते रहते हैं? ठीक है? Again, you can ask about the hopelessness कि आपको अपना मुस्तकबिल कैसा लगता है? So these are indirect questions. ये नोट कर लें. आजकल आपको जिंदगी कैसी लगती है? आजकल आपको जिंदगी और मौत के बारे में किस किस्म के ख्यालात आते रहते हैं? और आपको आने वाला मुस्तकबिल कैसा लगता है? So these are indirect questions, okay? Say if the patient is not opening up and still you suspect that there might be some suicidal intentions or ideas, then you can ask the direct question. Do you get the thoughts it is better to die than live? क्या कभी आपके ज़हन में आता है कि इस जिंदगी से मौत बेहतर है? Do you feel like getting away from it all and ending your life? Have you been thinking of killing yourself? और अगर मरीज कहता है कि जी मेरे ज़हन में ये ख्यालात आ रहे हैं इस किस्म के, तो फिर आप पूछेंगे उससे कि how often, कितनी दफ़ा दिन में कितनी दफ़ा आपको ये ख्यालात आते हैं? ठीक है जी. और क्या आपने कभी ऐसी कोई कोशिश की है? क्या आपको कोई प्लान है? और कौन सी चीजें आपको इससे रोक रही हैं? तो ये आगे हम इसको मजीद डिस्कस करते हैं, ओके? तो ये क्वेश्चन अगर आपने करना हो तो हाउ वुड यू आस्क दिस क्वेश्चन अबाउट द डेथ? आप खुद भी अपना फ्रेम कर सकते हैं कि आप यू कैन प्रोसीड फ्रॉम indirect question to direct question. There's a myth that one should not ask the questions about suicide because these may induce, suicidal thoughts in the patient. But this is not true. When you ask these questions,
with respect and with empathy, the patient feels more reassured. Okay? But you need to refine your skills to ask these questions. So this was suicidal intent. Then if he says that he gets the suicidal ideation, then you can ask about any plans, okay? क्या आपके जहन में ये ख्याल आता है अपने को नुकसान पहुंचाने का, तो क्या आपने कोई इसका कोई मंसूबा बनाया हुआ है? और अगर बनाया हुआ है तो आप कैसे इस पे अमल करेंगे? और आया आपने कोई मेजर्स ली हैं कि लोगों को पता ना चले? और कौन सी चीज़ आपको रोकती है कि आप इस पे अमल ना करें? ये बड़ा इम्पोर्टेंट है. ये हम इस बाद में भी हम आते हैं कि what is preventing you to carry out this idea, this plan? And Rumi says that walk patiently through this troubled world and you will find a great treasure. So there are many different problems, and if we are patient enough, we're likely to, get the great treasure. So in your book, the risk factors for suicide are given in detail. Personal risk factors, environmental, family, social factors. And I've tried to, summarize these risk factors here so that it's easy for you to remember these risk factors, okay? So, sad persons fume. Sad persons fume. So, S is for sex. Male are more prone to suicide. A for age and abuse in childhood. Younger adults and old age people are more likely to commit suicide. And D is for previous suicidal attempt or deliberate self-harm. To sad. Okay. Then is persons. P is for psychiatric and physical illness like cancer and depression, schizophrenia, bipolar affective disorder. E is for excessive drug use, that is drug dependence. R is for any recent stressful event such as death. And S is for single, separated, divorced. Okay. O is that the attempt was organized and there was serious intent. N is for no sports. And this S is for he still expresses intent to commit suicide, and there are social disadvantages, poverty, and there has been suicide among peers. So persons, sad persons. P, psychiatric and physical illness. E, excessive drug use or recent life events. S, single, separated, divorce, organized attempt, no sports, straight future intent, social disadvantage, suicide among peers. Fume. Fume is anger, okay? F is family history of suicide and family conflicts. Cultural factors. Some cultures, encourage suicide. And there are some cults which encourage suicide, okay? Which is called fatalistic suicide, okay? And when there is a, disintegration in the society, then there are more chances of suicides. U is unemployment. M is media cues like excessive publicity of celebrity suicide. And migrant population is more vulnerable. And E is easy access to beach. So kindly note it down. This would help you to memorize, okay? Should I move forward? Sad persons fume. Should I move forward? Okay. So these are the factors which make suicide more or less likely. Okay, this is increased if there is an immediate intention to carry out suicide, a choice of violent method, current symptoms of mental illness, recurrent alcohol use, past high risk attempt, and the likelihood of further bad news, that is the last straw. When there is a big event in the last 48 hours, the person was coping well, but has been a big event and he or she finds it difficult to cope with. And there has been a recent escalation of suicidal behavior, maladaptive behavior, help-seeking behavior, self-harming behavior. Okay? So high suicide risk is indicated if there is increased frequency or seriousness of attempts. So these are the risk factors and the factors which make the suicide and please note down this words, you might be familiar with it. So undoubtedly, along with the hardship, there is ease. Undoubtedly, along with the hardship, there is ease. ठीक है? बेशक मुश्किल के साथ आसानी है, बेशक मुश्किल के साथ आसानी है, सख्ती के साथ आसानी है. So now I come to the protective factors, the factors which protect people from, not committing suicide. And there are many. There is a sense of connectedness with the family, with the community, with the nation, with the world, with the humanity. Okay. If the person is married, okay, or has somebody to confide in, like mother, father, or friends, have children, has good social support, is resilient, okay, takes the difficulties as challenge, okay, and has, sound religious and spiritual beliefs. Please note that religion offers the greatest protection in the way of suicide in our culture. It's the greatest protection against suicide. Economic security, good health, and when there's restricted access to means, and when the psychiatric illness is detected early and treated early. For example, depression or anxiety or drug dependence. So these are the protective factors. These are given in your book, okay? The more the protective factor, more the protection to the individual. So in summary, we should establish a trusting, empathetic, and respectful relationship and ask about suicidal thoughts, plan, degree, method, and mean, background and current problems, hopelessness, worthlessness, and feeling of being trapped, symptoms of mental illness and or signs of psychological distress, past suicide attempts, or self-harm, preparation for final death, that is there, will or suicidal note or things, okay? In summary, you need to ask these things. So after having gone through these 6 areas, you would be able to now commit that whether the risk in this individual is low, medium, or high. And according to this risk assessment, you would plan the actions. So you would decide whether to admit the patient or treat him in OPD. A low-risk patient can be treated in OPD, and you would decide the level of the prevention and activation of family support. You would restrict the availability of any means of harm, and you would keep on assessing ongoing risks of suicide, and you would detect early and adequately treat underlying causes like severe depression. Okay. And again, counseling and psychotherapy. Same CBT is effective in, preventing suicide and in treating depression and in treating anxiety, cognitive behavior therapy. So whenever one gets suicidal thoughts, he might distract him or herself with, some other activity, mindfulness. You need to help the person to solve the problem which is given to the crisis. And this increase in purpose and meaning of life, okay, you can start volunteering work, you can start the activity of your patient, and you can help the patient to have a hope box. And he or she can collect in the hope box things which he or she values, things about his or her achievement, so that whenever he or she is depressed, you would open the box and would see, say, photograph of brother or sister, mother or child, okay? And you would help in relapse prevention. So WHO says that different countries should have plans for prevention of suicide, and they say it live life. What is live life? Live is leadership, intervention, vision, evaluation. And interventions are four. That less means interaction with media, forming the young groups and training them in different skills, and early identification and treatment of various disorders. And Rumi says, when you go through a hard period, when everything seems to oppose you, when you feel you can't bear one more minute, never give up, because it is a time and place that the course will decide. Never give up. Never give up. The key is never give up, whatever the circumstances are. Okay? So thank you very much for patient listening. Any question? I hope it was useful. And we can repeat it whenever we get time in the format of a workshop. So next lecture would be on panic disorder and unexplained somatic symptoms, okay? And I would be repeating the same management guidelines, and that would help you, okay? Thank you very much.